Assalamu alaikum. Today I am going to discuss a case of subluxated lens. As you can see, this patient has a subluxation of about 120 degrees, and I am going to manage this case with a capsular tension ring. The patient had dislocated lens in both eyes since birth. He is a 24-year-old man, and the dislocation in the other eye was such that the intraocular lens cannot be implanted in that eye. That eye has to undergo lensectomy. However, because in this eye the dislocation was up to 5 clock hours, so I've decided to try and stabilize the bag with a capsular tension ring and then place an IOL. The challenges in this case will be creation of the capsular axis because the lens is decentered, so I have to make a axis which is also slightly decentered and large enough to accommodate the IOL. The zonules in this patient were intact, which is a good sign. I do not want to go near the edge of the lens because I fear if I go too near the zonular insertions, the capsule may run to the periphery. Here I am done with the capsular axis. It is about 4 to 4.5 millimeter on the smaller side. I decompress the chamber, perform hydrodissection, and the lens rotates, which is also a good sign showing that the zonules are not in bad shape. Now here I decided to insert the CTR through the small side port, and later I will realize that in this case it would have been much better to insert the CTR through the main wound, which would have helped in dexterity and manipulation of the CTR in the bag. As you will see, the leading part of the CTR then entered the bag and now I am trying to do a 2 dialer technique, one to hold the CTR and the second to guide it into the bag. And here, as you can see, because the opening is so small, it is exerting a lot of stress on the zonules, and I am afraid that I might cause zonular dehiscence. So I stop, and I realize that it would have been much safer to enlarge the wound and then insert the CTR. Here I've enlarged the wound, and now it will be very easy to insert the CTR in the capsular bag. Here. So, lesson I learned was in such dislocated subluxated lens, it is better to always insert the CTR through a larger incision. I'm trying to chop the nucleus because this is a young patient, the nucleus melts at the phaco-tip, and now I realize that nucleus management is going to be tougher than I expected. It took me 3 to 4 minutes to complete this step because I didn't want to hurry this step up and cause a complication. So I lower my settings and start to trench. My plan is to create a central bowl and then hold the nucleus in the periphery and tilt it. This will also cause minimal stress on the zonules when I create a central bowl in comparison to direct chop technique. So the nucleus is rotating. Please also note I continue to sculpt. I am careful to sculpt deeper in the center and go shallow in the periphery to avoid punching a hole in the posterior capsule. And please observe that there is a lot of fluid leakage through the side port, which I enlarged to insert the CTR, and RS is prolapsing through the side port because the side port was enlarged. Now here I had tried to separate the nucleus. I lower my settings, lower my vacuum, because since there is a lot of leakage through the side port, I am afraid that as the nucleus gets eaten up, there may be surge and I might have to deal with the torn posterior capsule, so I lower my vacuum settings. I'm now chipping away at the mid periphery of the nucleus. Still, I'm not trying to go to the far periphery. Still trying to bowl out the nucleus. And this is a lot of tedious work. I had to exercise a lot of patience. Now here I get a small grip and I support the nucleus with my chopper and it goes back, so I have to hold at a new place. Here, now I've managed to prolapse one of the poles of the nucleus and I'm carefully chipping away at the equator of the lens. Now I am rotating the nucleus to get a hold of a thicker chunk of nucleus. And here I am again successful in prolapsing another pole of the nucleus. I use my dialer to gently guide the nuclear pieces into an hair. As you can see, I've managed to tilt the nucleus from the bag into the anterior chamber. I'm using my dialer again. I try not to move my phaco tip from the center, not to move it too deep, because there is a lot of leakage through the side port and I'm afraid the posterior capsule may come up and be engaged by the phaco probe. And this is the last piece, and here it's done. You can see the margin of the CTR, and now you can also see margin of the capsular axis. I am very careful to strip the cortex in a tangential pattern and not to pull the cortical sheets centripetally, which will cause excess stretch on the zenules. And I am stripping the cortical sheet first from the area away from the subluxation. And here I accidentally engage one of the sheets which was stuck in the CTR and let go immediately. I'm trying to strip it away, but I realize that it's not going to be that easy. Now I'm very carefully stripping away the rest of the sheets. Now this sheet is stuck. One of the disadvantages of inserting a CTR at the time of hydrosection is that it is very difficult to remove sheets. So now fill up the bag with viscoelastic, and in this case it would have been better to insert a multi-piece lens in the sulcus, but because of affordability issues by the patient, we had to go for a single piece foldable lens. And now at this moment I had thought that I would be able to insert the lens in the bag, but I did not realize that would cause a lot of stress on the already subluxated bag. Still, I try to attempt to insert one of the haptics into the bag, and at this point I realized that the lens is much larger than the rexes, and as you can see, the lens has pulled the subluxated bag to one side, and at this point I realized that it is better to leave one of the haptics in the sulcus. And here I push the haptic under the iris and hair. At this point I decided to leave this lens, part of it in the bag and part in the sulcus. I insert myocol. Now I do a final lavage of the anterior chamber to wash out the effect of the myocol, and this patient did excellently on follow-up. Please comment and give suggestions. Thank you for watching. The take-home message is: use 3-piece lens in sulcus to avoid stress on zenules and insert CTR through larger incision to prevent excess manipulation.